Hi everybody, it's Dr. Wright. The one subject that we haven't covered here, well, there are probably lots of subjects that we haven't covered, but the one thing that you see all the time in primary care is OtitisMedia. So I'm going to spend a little time talking about that. But as I started thinking about this, I was thinking that this is really the first unit where we have talked about taking care of ill children, and we have in several different places talked about ill children, but I thought I'd try to sort of summarize it all and just review it so that as you start thinking about kids being sick, as we get into more of these units, that everybody will kind of be on the same page. So let's go from there. Okay, we've mentioned this before. I think that children cannot explain their symptoms, but they don't mask their behavior, and they're normally active people. So you ought to place a great deal of store in the assessment of the child's general demeanor. Pediatric providers always have, as part of their objective data, the general demeanor, general, sometimes they just call it general, something to indicate their overall assessment of the child's general demeanor. So kids are not normally quiet and still, and that should always worry you. Also remember that parents know their children. If they think something is wrong, take it seriously. So when you look at general appearance, what are you looking at? You're looking at the degree of sickness and wellness, how many symptoms do they have, how high is the fever, that kind of thing, their mood, their posture, their activity level, their responsiveness to you, and their interaction with their parents. Take all of that into account and then start asking some questions of the parents as well about how they've been acting at home. If their fever is up right now, one of the questions you want to ask is, when their fever's down, are they behaving pretty normally? Because that's usually what kids do. Children have very resilient physiologic systems. They don't show a lot of physiologic change until things are seriously going awry. They do react rapidly with increases in heart rate to fever and minor illnesses. So they can get pretty tachycardic, much more so than adults would with a fever. They also get well very quickly. They have very active lymphatic systems and often display more lymphadenopathy with an infectious illness than adults do. So you're much more likely to find enlarged lymph nodes in any of the chains in the neck, even in the axilla, and sometimes in the abdomen and groin area. Experienced pediatric providers, when they have a child come in with fever and maybe a respiratory infection or any kind of infection that they think is likely to be viral, they always include an abdominal exam, even if they're not telling you they have abdominal symptoms. You check the belly and check the inguinal area, check for lymph nodes. Children sort of react in a more generalized way with their body systems than adults do. We see this oftentimes. For example, you see a child with OtitisMedia and mom will report that they were vomiting. It might be the virus, it might just be their reaction to being ill, which sometimes kids will do. Since kids are developing antibodies as they're exposed, they're very susceptible to infectious illness, and the younger they are and the less they've been exposed, the more susceptible they are. They get sick a lot when they first leave their home to go into daycare or school or anything else, and spend a lot of time homesick in those first few months because they're developing some resistance to all these things they're being exposed to. Young infants have immature immune systems and cannot efficiently localize an infection. They're at risk for developing sepsis. So because of that, we're always very suspect of very young children, especially young infants with fever. Now, a few words about fever itself. It's very common. Kids seem to react more with fever than adults do. Fever is a defense mechanism, and you can remind parents of that. How do you manage a fever? Be sure you have adequate hydration. Kids often stop eating and drinking when they don't feel well, so you want to be sure you're pushing fluids because it helps manage the fever, among other things. Treat with antipyretics. We'll talk about that a little bit more. You treat if the child's uncomfortable or the temp is rising rapidly. If the child has a low-grade fever and they don't seem uncomfortable, you can leave it alone. Fever is a defense mechanism. We'll talk a little more about dosing of acetaminophen and ibuprofen. Practice often have treatment guidelines printed for parents regarding fever. Remind parents to unbundle the child if they have a fever. You can use a tepid sponge for a very high fever, but you want it to be warm water, and you want to avoid shivering. If the child starts to shiver, you should probably take them out, because shivering is a heat conservation method of the body, and you're not doing any good if the child is shivering. Also, if you do use sponging as a method of getting the temp down, it takes about a half an hour after you sponge to see a result from it. So, don't expect to see it immediately. Fevers are a concern if they're very high, the child is an infant or young toddler, and the younger the infant, the greater the concern, and if there's no identifiable cause, you're even more concerned. Then you're worried about meningitis, sepsis, bacteremia, especially when there's no identifiable cause. So you want a PE and careful history for possible causes. Fever is also of a concern if it's sustained beyond about 3 days. Most viral illnesses, you won't have a fever that goes beyond 3 days. Child looks and acts ill, and or parent describes the child as not behaving normally even when the fever is controlled. So how do we treat fever? Acetaminophen 10 to 15 milligrams per kilogram per dose every 4 to 6. Acetaminophen has been available in 2 pediatric concentrations. This was in that little slide set that I put up for you about medications in children. It's been available in children's formulation and also in infant drops, which is much more concentrated. And the FDA did recommend that manufacturers go to only 1 concentration. This is because there are accidental overdoses. Parents get confused. Now all the pediatric acetaminophen liquids will be 160 per 5. And be aware that parents may still have the other form at home, but they're going to be confused about this. My daughter called me last week, as a matter of fact. She has a 9-month-old, and he needed something for some teething pain. And she called me and said, okay, I'm really confused because I bought what I thought was infant Tylenol, and it says to give him a lot more than I've been giving him, and I want to be sure I'm doing this right. So we talked about it, calculated the dose. So there'll be a lot of calls to pediatricians about this, although I've seen signs in pediatric offices indicating that hopefully they were doing some advanced education on this. Save the higher dose for situations where the 10 milligrams per kilogram is not effective. Remember that Tylenol is not a completely benign medication. It gets very toxic to the liver, and so if you need to go to the 15 because you're trying to relieve pain, then don't use it for any longer than you have to. Ibuprofen is given at 5 to 10 milligrams per kilogram per dose every 6 to 8. Use the 10 dose for high fevers. Once the fever's abating, use the 5 dose. There are 2 formulations here as well, 100 per 5 and 50 per 1.25. That's the infant concentration. I have not yet seen anything that indicates that ibuprofen manufacturers have gotten the message on this and are going down to 1 formulation. So I would imagine that we are going to see that in the future, because the recommendation was for all children's analgesics to go this way. So I think it's probably just a matter of time. You may see protocols for alternating ibuprofen and Tylenol in sustained fevers. Remember to give careful guidance, as this can be pretty confusing to parents. Studies of alternating have shown mixed results. There was a fairly large study by Hay in 2007 that showed that alternating was no more effective than ibuprofen alone. If you choose to alternate give the parents some very clear guidelines. I always tell them to write down all the doses that they're giving, and to be sure, and it's a good idea if you write down how much of each they can give and how often, and then have them keep a log of it, because your biggest risk here is confusion over the dosing and giving too much. Alright, so let's go back to the rule out sepsis concern. If you've got a very young child, an infant, especially an infant below 3 months, you are quite concerned about fever, especially when there isn't an identifiable cause, even sometimes when there is one, depending on how sick the child is. There's an algorithm in Burns in the section on fever that you might want to have a look at and review, even copy and take to clinical with you, might be helpful to you. And then the American Academy of Family Practice has I listed this as American Academy of Pediatrics, but it's not. That's a mistake. It's in American Family Physician. So the labeling of the link is incorrect. But down at the bottom here, there is a nice algorithm here too that you might want to go and have a look at. Let's get back to our slides where we were. Okay, so you need an algorithm to tell you when to do the WBC and when to do the urine culture, and then at what point should you really be sending this child off to the ER to get a lumbar puncture, because you need to rule out meningitis in children, especially when you don't have an identifiable cause of fever in a very young child. Okay, we've been talking about respiratory illnesses in children, so I want to just review with you some of the differences in the respiratory tract in infants and young children. They obviously have smaller diameter airways and a large tongue. This means they can obstruct their airway a little more readily, and the smaller airways can get obstructed with mucus a little more readily. Shorter, straighter eustachian tubes predisposes them to more ear infection. Infants, especially the first month of life, are obligatory nose breathers. It means you got to keep their nose clear if they get a cold. Use the saline nose drops, because if they can't breathe through their nose, they don't automatically open their mouths and can get hypoxic. The cartilaginous structures in the chest are less rigid. There's greater compliance of the chest wall. That's why you see retractions in young children. The chest wall tends to collapse more readily if there's obstruction, and they're generating a lot of negative pressure to overcome that obstruction. Infants have a smaller functional residual volume, and this makes them slightly more prone to pneumonia. I mentioned that in the narration on pneumonia, a lower respiratory illness. Newborns have thicker alveolar walls, making gas diffusion a little bit slower. There are less muscles. There's less muscle tissue in the small bronchi and bronchioles in young children, which means they also collapse more readily. So in these kids, you tend to see more wheezing. A good example of that is bronchiolitis, which is in the lower respiratory lecture, where you get kids who get some inflammation of those smaller airways, and those airways tend to collapse down and they start to wheeze. There are more mucus-producing structures per unit of surface area in their lungs, and this means that kids are just gunky, and they're gunkier than adults are, because there's like more mucus in a smaller volume. They have a subglottic narrowing of their airway that predisposes them to croup. They have an advantage, actually. Their alveoli continue to increase in number until they're about 8 years old, which means kids can actually heal their lungs in ways that adults can't if they're damaged. There's a very rapid growth of lymphoid tissue in children. We see this with, as we said, a lot of lymphadenopathy. but it regresses after age 10 or 12. This is one of the reasons they kind of stall on doing tonsillectomies on kids, unless they're really obstructing their breathing, or they're really frequently infected. But if they're just large, they tend to leave them because they'll actually relatively get smaller in size after 10 to 12. They tend to not grow anymore, and then of course the throat itself gets larger too. So it tends to be less of a problem after that. Okay, how do you manage colds in children? We already talked about managing colds in general, so some of those same things there were mentioned in the previous presentation. Elevation of the head is always helpful when you've got a lot of nasal congestion. For infants, put them in an infant seat. Remember, no meds for children under 6 years of age, no cold meds. So parents really have to rely on those saline nose drops in the high humidity. And cool humidity is often better because it shrinks the mucous membranes. Now in kids over 6, you can use the same things you can use in adults. Antihistamines, decongestants, cough suppressants, expectorants, pain relievers. Most people have no idea about the differences between these. So you need to sometimes do some education about what each one of these is for. What's the difference between an antihistamine, which is a drying agent, and a decongestant, which helps open up the nose? And do you need one or do you need both? Over-the-counter combinations, be alert to overdosing, particularly on acetaminophen. I usually tell people that they're better off taking individual ingredients because, you take an over-the-counter combination and you may be taking medicine you don't need. Maybe you don't need the antihistamine, you just need the decongestant. So I don't know if that's advice that your providers will follow. If somebody has a good over-the-counter combination that's working for them, it doesn't mean I'm going to tell them not to use it. I just think sometimes there's an advantage to taking your ingredients separately as opposed to all together. Also, it's very hard to know what's in the OTC combinations because they change all the time. And for example, now the only really effective decongestant is Sudafed. And you have to get it from behind the pharmacy counter. But tell parents they can get it if they need Sudafed for their child or for themselves. Adding to that confusion, of course, for the over-the-counter stuff is the fact that the company that uses that name, Sudafed, now makes cold medications that actually have no pseudoephedrine in them. So it's really confusing for parents. They don't know what they're taking a lot of the time. Okay, let's go to talking about the ear. So this is the normal structure of the ear, and we see the eustachian tube here and the middle ear chamber here, and the eardrum and the external canal. Now this is actually a model of an adult ear because you see there's a nice slope to this eustachian tube here, and the younger the child, the sort of flatter this tube is, and it's more horizontal. So this means fluid backs up in here, gets right into the middle ear right here, and sits here because this swells, and then it doesn't drain well, usually with a cold, and then of course sits here long enough, bacteria begin to grow in here, and then as fluid fills this space, you see the tympanic membrane bulging out, and you see inflammation of this membrane right here. So in acute otitis media, you see a pattern similar to sinusitis. In other words, it most commonly occurs at the end of a URI. It can occur more chronically in kids who have chronic fluid in their middle ear, or in kids who have a lot of allergy where their eustachian tubes swell as a result of allergy. Sometimes you'll see sort of chronic ear problems in those kids too. So the history you commonly see is a recent URI, fever, often night waking and crying. In a young child, if they've had a cold and parents are telling you that they're waking up at night and crying, suspect an otitis media because you lie down at night, that fluid increases in the middle ear and they wake in pain. And during the day, they at least have gravity helping to drain that middle ear a little bit, I think, and tends not to be as bad. Sometimes you'll get the story that the child seemed to be improving and then wasn't anymore, or got worse, or just wasn't really getting better from their URI. Sometimes they have other constitutional symptoms, lethargic, not eating. We talked about vomiting, which sometimes occurs with otitis media. Ask about passive smoke exposure because there's a much higher incidence of otitis media in kids exposed to cigarette smoke. Your PE findings should include both symptoms of middle ear inflammation and the presence of middle ear effusion to have a diagnosis of acute otitis media. So what tells you the middle ear is inflamed? The tympanic membrane is erythematous. This can vary from pink to very dark red. The child has ear pain. This is a result actually of both the inflammation and the fluid. There's something called bullous otitis media, which can present with blisters on the tympanic membrane, and it's not as common as the garden variety type, but just be alert for it because you look in the middle, you're looking at the eardrum and you're trying to figure out what's going on with it because it looks like there's a big bubble of water or multiple bubbles of water sitting there in front of your otoscope, and that can be bullous otitis media. It's like blisters on top of the tympanic membrane. The middle ear effusion, you either won't be able to see the landmarks at all, and the absence of the landmarks says that there's middle ear effusion, or you may actually see the tympanic membrane bulging out towards you. If you just check for mobility of the tympanic membrane, you will find limited or absent mobility as the membrane bulges outwards. You could see otorrhea, drainage from the ear, if the eardrum ruptures. So you always want to ask about that. Treatment. First treatment is reduced pain, acetaminophen or ibuprofen. Anesthetic ear drops, Aralgan is a common popular one. Be sure the tympanic membrane's intact if you're going to use Aralgan because it shouldn't go into the middle ear. And warmth of the ear will sometimes help. The guidelines now say that if a child is over 2 and the child is not in pain or the diagnosis is uncertain, that you might want to wait 24 to 48 hours and see what happens with the ear. There is evidence that a lot of mild otitis media, if there is such a thing, a lot of mild inflammation of the middle ear actually resolves on its own, particularly if the child's had a cold. So you can just do the watch and wait. If they're in pain, it's a different story. And the guidelines say under 2 years of age, if the diagnosis is uncertain, it's okay to go ahead and treat. Since there's the studies on this have generally been done in kids over 2. Less than 2 years, there's also a higher incidence of complications from otitis media. So you can have the parents call you if the child isn't better within 24 to 48 hours. You can also give the parents a prescription for the antibiotic and ask them to wait. The studies on this have shown that parents often will wait, interestingly enough. We think parents always want antibiotics, but sometimes I think what they want is to know that they have it available to them, and that they won't find themselves with a child who's in a lot of pain and they won't be able to get in to see a doctor. It'll be in the middle of the night or something like that. And if the child has a history of ear infections, parents don't want to be in that situation. So you can explain it to them. Tell them that the way the ear looks, it might just resolve on its own, and since antibiotics have side effects, particularly GI ones, that if they could wait 24 to 48 hours, it might resolve and they wouldn't have to use the antibiotics, and that would be better for the child. And the studies show that actually a lot of parents will wait. This particularly works well on a Friday afternoon when parents are worried about the weekend. What therapy are you going to use? First-line therapy is amoxicillin at the high-dose formulations. Remember that strep pneumo in particular secretes penicillinase, which inactivates the amoxicillin, so you have to give a lot more of it to overwhelm it. So you should use the 80 to 90 milligrams per kilogram per day when using amoxicillin. You can use cephalosporins in children who are penicillin sensitive if they did not have type 1 reaction. Type 1 is anaphylaxis. So if this is a child who just had a rash, it's fine to use a cephalosporin with them. Keflex will work. It's a first generation cephalosporin. It's cheap. You can go to second and third generations too, but the Keflex is cheap and it comes generic and usually works pretty well for otitis media. Azithromycin you can use in children who had a type 1 sensitivity reaction to penicillin. Sometimes parents ask for azithromycin, particularly in a child who is difficult to give medication to, and of course the reason they want it is that it's only once a day and it's only for 5 days. So that sometimes is a reason to give it, because if they absolutely just have to fight with the child for every dose, sometimes they spit out so much of it that you wonder if they're getting enough. So you have to kind of gauge that. And augmentin should be used in children with frequent recurrences or with severe illness. Now remember, augmentin is amoxicillin with clavulanate in it, and one of the things about dosing augmentin is that it's pretty confusing. So find out what your preceptor normally uses. Now I want you to go to your formulary and I want you to look at the augmentin liquid formulations. There are 5 of them. Okay. They're listed by the amount of amoxicillin in them. So 125, 250, 125, 200, 250, 400, and 600. But they have different amounts of clavulanate in them. The 125 and 250 have a ratio of a higher amount of the clavulanate in them than do the 200, 400, and 600. Now why would that be important? Because if you're giving more amoxicillin, you don't necessarily want to give more of the clavulanate. I always have trouble saying that, because that's what causes the diarrhea and the GI upset that goes with augmentin. What I do personally is usually use the 400 per 5 or the 200 per 5, which have the same ratio. The two of them have the same ratio of clavulanate to amoxicillin, and it's less than the 125 and 250, and the 600 is even less. But I usually use the 200 or 400, dose it twice a day. That usually works quite well. So ask about this when you are doing your pediatrics. Find out what providers are telling you about this. See if they follow these same sorts of guidelines for the use of augmentin. The clavulanate is there to overcome the penicillinase, and it doesn't seem like you need large quantities of it in order for it to work. Okay, many offices recommend an ear recheck after 3 to 4 weeks, since a certain percentage of children don't clear their middle ear effusion real well. And if this goes on for a long period of time, this can affect hearing and speech. Honestly, I think you ought to wait longer than 3 to 4 weeks. That's what I see a lot of offices do. But when you see kids at 3 to 4 weeks, they often still have a little bit of fluid, and you end up bringing them back anyway. So I think I usually would go out further than that and do, 4 to 6 weeks and see them back and see if the ear is completely cleared at that point. For kids who have middle ear effusion, that goes on for long periods of time. They may need to be referred to ENT for evaluation for tympanostomy tubes in order to preserve hearing and drain the middle ear. But they're a small percentage of kids, but you will see those kids in practice, and it's always a dilemma about what to do to help them. Generally, decongestants don't help middle ear effusion very much, and There are a few off-label things that are sometimes done. Sometimes nasal steroids, interestingly enough, are used by some of the ENTs to see if it'll open up the eustachian tube. As you spray it in the nose, it kind of drips down into the posterior pharynx and past the eustachian tubes, and sometimes the thinking is it'll help open up the eustachian tube so that the ears will drain. That is an off-label use of it, but you may see ear, nose, and throat people using it or giving it a try. So that is Otitis Media. Ask questions. Report back on what you're seeing in practice in terms of management of Otitis Media.